Welcome to Have You Heard? An IDF podcast. This podcast is a service of the Immunodeficiency Foundation, a nonprofit organization that improves the diagnosis, treatment, and quality of life of people affected by primary immunodeficiency. People living with PI are the zebras of the medical world, and the IDF community is one big zebra herd. Chronic Granulomatous Disease, or CGD, one of the rare forms of primary immunodeficiency, causes an increased susceptibility to infections caused by certain bacteria and fungi. In today's diagnosis-specific episode, we'll be exploring treatment options, particularly bone marrow transplant for CGD. All right, let's get started.
Hi, welcome to the Living with CGD podcast with the Immunodeficiency Foundation. Today we will have a discussion about bone marrow transplants. My name is Felicia Morton, and I am the Executive Director of the CGD Association of America, and I'm very pleased to have with me today Dr. Vinod Prasad. He is the Professor and Director of the Pediatric Transplant and Cellular Therapy Division at Duke University Hospital. I'm also very pleased to say that he helped us a great deal. That's really an understatement. My son, Sebastian, was a patient of his, and we're so grateful to him for the successful outcome of Sebastian. So thank you, Dr. Prasad, for joining us today.
It's my pleasure, Felicia. And anytime I have the ability to talk to our parents, patients, anybody who is struggling at making decisions about what to do with their child or about themselves when you have a really serious life-threatening condition, if I'm able to help, I feel privileged to do that. So I'm happy to provide any information you need and thank the IDEA Foundation to be able to host these podcasts and send the message.
Yes. And I know because I've been there, and well, we've been there, my husband and myself, when we were struggling with one of the most difficult decisions a parent will ever have to make, which is to determine whether or not to go through with a stem cell transplant or to continue to live with chronic granulomatous disease. Of course, unlike other diseases that are malignant or even immune deficiencies, with which CGD is, and we'll get into what CGD is, and it would be great if you could give us an overview of that, Dr. Prasad, because some of our listeners might not know exactly why it's important to think about these types of treatments and when and where it's best to do it. But we know how difficult it is to make that decision, because you can live with it or you can go through treatment, and both have very difficult and challenging risks associated with them. So how do parents make that decision, and why is it important to think about this decision for parents of patients with CGD or for patients themselves with CGD?
Absolutely. I think that's a very important question. I'll divide it into two parts. First, let me briefly tell the audience who may know CGD very well or who may not know all the aspects of CGD. So what CGD is, and then we will talk about what options there are for treatment and the curative option, which is performing a hematopoietic stem cell transplant, also known as bone marrow transplant, or some people will call it stem cell transplant. So I've said this before to you, Felicia, that I've been involved with patients with CGD for almost 30 years. I probably saw my first patient with CGD, a 15-year-old girl in England when I was training in England in late 1990s, early 1991, or somewhere in that time frame. And the patient has had three problems. One is she used to get a lot of infections. Number two, she used to have granulomas, and she used to be in and out of the hospital. So if you look at the diagnosis, which is CGD, which stands for Chronic Granulomatous Disease, it conveys three things. It's disease, it's a syndrome, it's a collection of multiple problems which are chronic, which means that they are long-standing. And in addition to infections, the patients also develop granulomas. Granuloma is another way of saying, medically speaking, that there are certain areas in the body that have developed nodules that could be external in relation to lymph nodes, or they may be internal in relation to the lungs, in the colon, in the kidneys, in any other part of the body, where they can then cause compression on vital organs. And so CGD is a chronic condition which leads to multiple infections, granulomas, and a number of other problems, including immune mediated problems. For example, immune mediated hemolytic anemia or immune mediated thrombocytopenia, which is impact on the blood forming cells because of immune system dysregulation. That was the initial description of CGD, but over the years, genetic developments have led to specific diagnosis on the basis of genetic testing, and all of these diseases are caused by a mutation in one of the other genes that lead to this immune deficiency. And I don't need to really get into the details of specific genes involved, which that information is available easily. But I would bring it to this conversation to the idea of treatment. And that is, over a period of time, you can continue to have a reasonable quality of life if you're able to control the infections with appropriate prevention as well as treatment with antibiotics, antifungal medications, and other treatments. Early detection of infection and appropriate and full treatment of infection really improves the quality of life. However, patients also get, as I said before, immune-mediated problem for which, depending on which organ is involved or which tissues are involved, you have to use appropriate treatment. And sometimes it can be very tricky. A lot of these children also will have impact on growth and development, their nutrition, and those have to be addressed as well. However, you can continue to do the supportive care for a period of time, but the disease doesn't go away. It always comes back, it always leads to infections and other complications over the years, and significant impact on the quality of life, on the growth and development of the child, in and out of the hospital, takes toll on the children as well as on the families. And the only curative option that we have right now is to do hematopoietic stem cell transplant. So your question was initially, how do you make that decision of when to do hematopoietic stem cell transplant? And in my mind, the parents have to make that decision on the basis of three really specific pieces of information. The first is how severe is the disease? Now, I, of course, in a podcast cannot get into all the details of assessing severity in a patient with CGD, but if the child has had a major life-threatening infection, it certainly is one of the measures of severity of the disease. So if you have severe disease, doing transplant early is an appropriate decision, and we can talk more about it. The second piece is to have an appropriate donor. Now, how we define appropriate donor is a detailed conversation, and I'm sure you will ask me more questions related to that, and I'll answer that. So if you have severe disease and you have an appropriate donor available, and the third piece is access to a good transplant center where you feel comfortable, confident with the team that they will make the right decisions for your child and would be able to take care of child. Once you have those three pieces, I think it becomes easier to make a decision to move forward with transplant. Now, of course, it's a very personal decision, and your expert physician, a transplant doctor, should be able to help make that decision with you in any specific case. So I hope I answered your question in a very long way.
I always appreciate your answers because they're so well thought out. And I learned so much from you, Dr. Prasad. And in our case, Sebastian did fill a lot of those boxes, given the severity of his CGD. And yet we still struggled with the decision about when to go forward with transplant. Of course, for a parent, there's never a good time. And it's counterintuitive to think, well, when my child is at its healthiest point, that's when we should go into transplant. And so, if you had to say, Dr. Prasad, I know it might be difficult, is there an ideal time for a patient to go through transplant?
There isn't an ideal time. The ideal time depends on the specifics of a particular patient. But as a general statement, it's true for CGD and it's true for any other disease that requires transplant. And that is, you need to do the transplant before significant infections have taken a toll on your organs and before your organs have been negatively affected because of the disease. So, in the context of CGD, multiple infections can impact lungs because, as you know, pneumonia is a common infection in patients with CGD, and that may have compromise lungs' ability and its function. You want to do transplant before that happens. Some patients may have a negative impact on the kidney because of pressure of one of these granulomas on the kidney. I remember a patient who actually had to have a kidney removed even before they came to us because of compression on the kidneys. So you want to do the transplant before there is major damage to the organs. So that's really important. And then the other piece is that you have to start looking at the transplant option early and start looking for a donor. The donor could be in the family. If there isn't a donor within the family, then you start looking for unrelated bone marrow donor or unrelated umbilical cord blood donor, depending on the specifics of the case. But once you have an idea that your child or you are suffering from severe disease, then waiting is not going to make the transplant outcomes better. Um, Prolonged delay will only make the transplant outcomes worse, and that's why it should be done early. So, we have transplanted children who are less than 1 year of age, and as well as children who are older, going up to 12, 13, 14 years of age. And I have to say that going through transplant for a 1 year old is not more difficult than a patient who is older. If anything, I think it's easier to take the younger kids through transplant because they don't, in the long term, remember a lot of the difficulties of going through transplantation. They recover very well, and the younger you are, I'm not talking about very young babies. I'm not talking about premature children, but I'm talking about late infancy and later on. The younger you are, the more resilient your body is to take on the chemotherapy and respond to transplant. So earlier the better.
Yes, and one of the issues that you touched on was finding a donor. My husband and I are mixed ethnicity. I am Caucasian, he is Hispanic. And so we didn't realize at the time that this would be a challenge for us in terms of finding traditional bone marrow through the National Bone Marrow Registry. And so that's one of the reasons why we decided upon Duke after doing all of our research and meeting with different transplant centers of excellence. And that's a tremendously important point, Dr. Prasad, as you said, to research the various hospitals that are known for transplanting CGD and having an excellent reputation like Duke. So thank you. And we do need to take a quick break. So stay with us and we'll be right back.
No matter where you are along your journey, IDF wants to help you manage living with primary immunodeficiency, or PI. As a community-empowered organization, IDF can provide you with support, education, and resources to help you cope with a wide variety of issues related to PI, including physical and mental health, insurance, and relationships. For more information, please visit www.primaryimmune.org.
Welcome back. I am here with Dr. Vinod Prasad discussing transplants for CGD. Thank you for joining us again. One thing that Duke does have that sets it apart is its umbilical cord program. And could you tell us a little bit about that? That's what we did use for Sebastian, and it was one of the only options we had available. Haplo-identical might have been a possibility too, and that gets into some of the other decisions that parents have to make or patients have to make, which way to go, depending on what's available. But if you could tell us a little bit about Duke's umbilical cord program, what makes it unique, and also how parents get into those decisions regarding what type of transplant is best for their child.
No, absolutely. I think that's a very critical question. And if I could just spend maybe a couple of minutes talking about all the various transplant options or donor options there are. Any patient who needs a transplant, the first thing you want to do is do a test from the blood or from a mouth swab called an HLA typing. HLA stands for human leukocyte antigen. And once you have that result on a patient, then you can start looking for potential donors. And if you have other siblings, if the patient has other siblings, then we would, the first step that we would do is to do the HLA typing on the siblings, and in most cases also on parents. Some patients may be older and they may have their own children, and in that situation, you would do the HLA typing on their children as well. So the immediate family, you would do an HLA typing. And without getting into too much of the genetics of this, there is, for any sibling, there is about 25% probability that any given sibling will be fully HLA matched with the patient. And there is about 50% chance that the sibling would be half a match or haploidentical match. So in general, if you have more siblings, there is a higher probability of finding a matched sibling as a potential donor who is fully HLA matched. But in the United States and in most countries, Western European countries, the probability of finding a matched sibling donor is about 25 to 30%. In certain situations, it may be higher. In certain situations, there may not be any siblings. So in about 2/3 of the patients, we have to look at other options. And we would call that as alternative donor options. And I would place those options into 3 different buckets. One would be to look for an unrelated bone marrow donor through international and national registries. In the United States, the registry is called National Marrow Donor Program. It's NMDP, also known as Be the Match, and it's a federally funded program which has in its registry many million potential donors who have volunteered a blood sample or a cheek swab and have been HLA typed, and they are in this registry, and you can look for an appropriate donor from that registry. I'll go into a little bit more detail in a little bit later about the NMDP part of it, but an unrelated adult bone marrow donor would be the first of the 3 buckets that I talked about. The second option is to find an unrelated umbilical cord blood unit. And a little background about umbilical cord blood is when a baby is born, any baby is born, placenta and the tubes that are attached to the placenta and the baby, that is thrown out as an afterbirth. But over the years, research led to a conclusion that there are enough of really good cells in the placenta, placental blood, and the umbilical cord blood that can be saved, and there are enough hematopoietic stem cells or progenitor cells that can be used for transplant. So using umbilical cord blood, Duke was the site for the world first unrelated umbilical cord blood transplant almost 30 years ago. Since then, about 30,000 umbilical cord blood transplants have been done around the world. And so now there are a number of public cord blood banks that are present within the United States as well as in other countries that we can access as a patient's physician to look for an appropriate donor from unrelated umbilical cord blood banks. And the third bucket is what you had mentioned as haploidentical. So in last few years, we have been able to, we as in the transplant community, has been able to use half-matched siblings or parents as potential donors. So truly today, I feel so fortunate in the being in the field of transplantation that we can almost always find a donor for a patient who needs a transplant, compared to when I first saw my CGD patient. That patient did not have any siblings, and transplant was not even an option. And I don't know how she's doing now, 30 years later, but it's highly unlikely that transplant would have been done for her by now. So those are the three buckets. You have the option of using an unrelated bone marrow or an unrelated cord blood or a haploidentical. The data for unrelated cord blood and bone marrow transplant, unrelated bone marrow transplant is excellent. The data for haploidentical is still maturing, so it's a little bit difficult to say. But in any given patient, we have a number of options, and we should find the best donor and use the best donor for transplantation.
Agreed. And thank you so much for that overview of the options available to patients. And not every option is going to work depending on the match. But thank goodness for the advances in medical science to get us to the point where almost every patient can have access to a donor. Certainly Sebastian had an interesting mix given my background, and my relatives hail from Finland and Austria and Lithuania, and my husband's are from Costa Rica. There are very few matches, I think in the registries that would have that combination together. So we were very relieved to know that we did have an umbilical cord match that would work for Sebastian. And we didn't talk about gene therapy. Many in our community, in our CGD community, are thinking about gene therapy. There have been some advances in the last few years. There have been clinical trials, and wanting to know your thoughts on that as an option as well for our patient population.
Absolutely. I'll come to gene therapy, but as you were talking about Sebastian, I sort of remembered something about umbilical cord blood, and I thought just talking a little bit more about that would be helpful for the audience. And that is that when you do umbilical cord blood transplant, the need for HLA matching is not as stringent as you would need for an unrelated bone marrow transplant. And that's why we are able to find an unrelated cord blood almost for everybody, despite having the mixed ethnic and racial background, and even for the most complex ethnic situations, I think there is a more than 90% chance of finding a suitable cord blood unit for a child with any diagnosis who needs a transplant. So umbilical cord blood, we have significant experience at Duke, and certainly feel very comfortable in using mismatched umbilical cord blood if that's the best option that there is. And now coming to gene therapy, just the concept first is, as I had briefly mentioned, that on the basis of further genetic research, it's clear that CGD, like many other diseases, is a genetic disease and there is a defect in one particular gene. It may be a different gene depending on whether you have a X-linked recessive type of CGD or you have an autosomal recessive type of CGD, but there is always a gene defect that leads to CGD and many of the other genetic diseases. So it stands to reason that if you could fix that defective gene, then it would be therapeutic and it would be curative. But the concept is easy. The idea of gene therapy has been around for 30 plus years, and huge advances have been made in the field of gene therapy in the last 30 years. There are certainly some diseases that have gene therapy that have gone through appropriate approval process in different countries. CGD is the gene therapy of CGD is in the early stage. It's not yet approved, but some really brilliant scientists are working on it, and there is a lot of interest in it. And I would suggest that we certainly consider gene therapy as an option if there is a clinical trial that is open at the time that your child needs treatment or you need treatment, and then reach out to those clinical trial groups and see if you qualify for the gene therapy clinical trial. So gene therapy would be in the clinical trial stage at this stage.
Right, right, and it's true that more research needs to be done, and it's not FDA approved yet. But to look into clinical trials at clinicaltrials.gov would be a way for our patient population to begin that research and seeing what is possible. And we're coming to the end of our time. This has been so wonderful, Dr. Prasad, as always, talking with you. And so I wanted to ask you some of your thoughts about how families can prepare themselves for this procedure and given all that takes from them. And I think one thing I do want our community to know is that it's really important, in addition to asking transplant hospitals that they're considering about the successful outcomes that they have for their patients, what other support they provide to care for the whole family. And one point I'd like to make when I say the whole family is that in our case, the thinking was to leave our daughter at home in New York, where we live, with family here and not uproot her. This is just one consideration to make. But I remember you saying, Dr. Prasad, it's better to keep the family together because, the thinking was, well, we don't want to uproot her and we don't want her to miss out on her schooling in New York. And it might be difficult for her to be exposed to all of these challenges that Sebastian's going to be going through. But you had advised us to keep the family together, and we were able to find a school for her. She was in third grade at the time in North Carolina, and she was such a wonderful part of his healing process. And so that's just one aspect for families to consider. But I was wondering if you could give us a little bit of your insights on that as we close this wonderful podcast and end us on this, sort of hopeful note for parents.
Absolutely. I think when you said that I don't want to sugarcoat, I think it's really important. The transplant is not an easy procedure to go through, either for the patient or the family. You almost have to commit 6 months to a year of your life to this treatment. Depending on where you live, you have to move to live close to a transplant center. If you're fortunate to be living close to a transplant center, you could probably still stay at home. But during the first few months, you really need to be almost within a few miles of the transplant center because complications happen. You have to be rushed to the hospital, and minutes matter in those situations. So the first point is that it's not an easy treatment. It requires a lot of thought, not only for the child, but also for the whole family. And you have to move and live close to the transplant center. The second is that it's not a treatment without risk. There are short-term risks. There are some long-term risks that one has to consider. And your transplant doctor should be able to give you all that information. And I'm always available to any patient with CGD or immune deficiency. Anybody who's listening to this podcast and have any questions about how to get more information about transplant, please feel free to send me an email or contact our office. The third is to try to keep the family unit intact as best as you could in any given circumstances. And talking about Sebastian, yes, it was good to have his sister around. So he had a support network of not only parents, but the person he loves most, and that's his sister. So maintaining those kinds of family units, I think, is really, really important. Number four is that it's a long hospitalization. Depending on your specific case, you may be in the hospital for 2 months, 3 months as you go through transplant and recover from transplant. And during that period of time, at least at Duke, we have set up the unit in such a way that it has the most stringent infection control and other technical um, requirements fulfilled, but also try to maintain some kind of a normal child environment. So there's a playroom with specific rules of when and how it can be used. There is a place for children to, in the corridors that they walk and they run and they play. We have child life support team that helps the children as they're going through transplant maintain as much of a routine childlike environment. So I think those are all really important. But the most important thing is that if you're considering transplant, consider it early. Meet with a transplant team, either virtually, these days that's very easy, or in person. Ask all the questions that you have, and then make a decision of where to do the transplant and how to do the transplant.
Dr. Prasad, it has been so great meeting with you and talking with you today. Thank you so much for all that you do to advance science for the CGD population. Thank you so much for the care and the time that you take with every patient to explain the procedure, to help us understand, and for the work that you do for those who are under your care. We're indebted to you, Dr. Prasad, and we are grateful for all that you do and for your time today.
Felicia, it was such a pleasure to be with you, having this conversation, and in the process, also giving me an opportunity to talk to the families and patients with immune deficiency. I want to thank everybody at Immune Deficiency Foundation and also at CGD support groups who are trying to bring as much information to the families and the parents as possible. And I, for one, would always be available to any family or parents. Please share my email address, which is my first name, Vinod Prasad, Prasad, at duke.edu. So thank you very much, and hope to see you another time. Thank you.
This podcast is a service of the Immune Deficiency Foundation. If you like our show and want to learn more, please subscribe to this podcast so future episodes will be sent to your device automatically. To learn more about primary immunodeficiency and the PI community, please visit the IDF website at www.primaryimmune.org. And if you have a question you would like answered, email us at idf@primaryimmune.org. Thanks for tuning in.